So coming on, this is all for the rehabilitation and this, but we are also looking for something in the diagnostic field also. A very important thing that we like to do is drug level monitoring. We have a lot of anti-epileptic measures, we have a lot of chemotherapy measures, we have a lot of drugs which have to be titrated, particularly in our on day-to-day OPD basis. And each drug has to stay in a particular optimal therapeutic range. So we are not sure whether, and each patient behaves differently. Not all patients will have, if you are giving 200 milligrams to one patient, it will not have a uniform level in every patient. So it's better, we ideally want to titrate these medicines and how each patient is living. But these drug levels are usually done by high-end mass spectrometers, which are not usually available in every city and center. So we would like something of a cheaper alternative or a point-of-care device which can have multi-drug level monitoring. If it measures more than one drug, it's well and good. And if it also measures some toxins, for example, if you're seeing some toxins or acute poisoning in the emergency, we can just have a point-of-care device which can measure toxins or drug levels in each of these patients. So very important part what we neurologists see is seizures. We do have EEGs which can measure abnormal electrical rhythms which could cause seizures in the brain. But we want something, and patients have to be admitted for video EEGs or continuous monitoring to monitor whether these patients are having seizures. We have ambulatory EEGs, but something of a wearable device which can be there or much cheaper alternatives can also be helpful in detecting and predicting seizures in most of these patients. If you use a machine learning algorithm, you can also predict seizures in which of these patients can have a seizure based on it, and you can have a therapeutics design for that. And coming to the last subject, we need a lot of point-of-care devices because large number of devices which most of the neurology departments across the world have are large machines which are fixed in your labs, which are difficult to carry everywhere in and around, and patients have to be referred everywhere. What we like is to have something, these devices, like just now I told you, a portable EEG or ambulatory EEG, or we want something like a portable nerve conduction studies. Nerve conduction studies is two electrodes recording a potential difference between two objects using a stimulator. Those devices can be converted into a very small platform, which can be used to distribute everywhere, and this can be not only used by the neurologist, it can even be used at the level of the general physicians also. So we are decentralizing healthcare at this point of time also. So we can have a lot number of changes if you just bring down the cost of these devices and make them more accessible to the general public and even the general physicians also. Other point-of-care devices like to use of ultrasound device, look at muscle fibrosis or loss of muscle at one point. These can have a lot of applicability in avoiding some major investigations altogether. These are not the only problems that we have. We have a lot many problems, but because of our limited time, these are the few common problems which I have chosen to highlight upon. Rest of the problems I think we can all discuss. I have my entire team here. We have Dr. Manoj, Dr. Kamlesh, Dr. Sucharita, and Dr. Ritu. We can all discuss if we have a little more time. And hope with this meeting we can have some conclusion or some innovation that we can bring about. Thank you. I think if anyone has any comments or questions. Yes, sir.
This is a normal doctor, but AI fanatic. I work with one of the most genius people in this era.
Yes, please.
So I've been working directly with the chief innovative officer of State Bank of India. So we are the one who made India digital for UPI payments. His name is Mr. Sudeep Marokar. He has his own website by sudeepmarokar.com. I really want to know that you brought the most exciting factor at the end of slide, and AI is something that we are fanatic about today. And exoskeletons is also there, but I really want to know what is the differentiating factor that is not there in the global sense in the exoskeleton that you have. Because the differentiation would be there, right? So what we are different.
We are actually looking at something they have developed. Most of these ideas are not new, but what we have to do is something which we can make applicable here. These devices, which I say exoskeletons, are very expensive devices. They have been there for the last 40 years, actually.
Correct.
So these are nothing new. But what we want, this I have not seen a single exoskeleton in my practice. If most of my patients are still bedridden, why we have to rely on the technology which is very expensive and very patented? We do have newer drugs which are still patented in the US. We are getting at 1/10, 1/100th of the cost in India. Chemotherapeutic agents, why can't we bring the same technology? I am not sure how much is an exoskeleton, is a high fidelity device, how much patented technology does it use? Most probably, the majority of the technology would involve around designing a chipset with simple programming, detection of motion, and actual relay of how much power or movement should be there. These technology which was developed 40 years ago in some lab in the US can be easily replicated in our setting. These can be easily replicated, and the cost can be brought down significantly. $40,000 is a huge amount for any Indian patient, let alone a middle class or lower income. I want something which is very cheap and simple also. We had designed a Rambler, which we made at the cost of around 2,500.
So the main thing, Karthik, please. You don't have a second mic, so I have to come here. Main thing is we want it in bulk for poor people of our country, not for the high end. Okay, for Barack Obama, something will come. They will put him on exoskeleton also or something also. We want simple things which are available which can be produced in market and which can be just we write a prescription. So buy this will improve your quality of life. Like that fecal incontinence, as Dr. Karthik has pointed out, is not only for neurological disorders. In elderly people, so many elderly people are suffering from it. Just bed sores, all that. Diapers work for children. Diaper is a very good innovative solution. Correct. But it does not work for adults. Correct. So we want some simple device which is just available for say 1,500, 2,000, which can be produced in bulk and given to each and every patient, irrespective of his or her, standard of living or everything.
Doctor, if you're complete, I have a thought because I don't want to miss it out. I connected upon a point that you were discussing, which was brain-machine interface models like Neuralink, and that is something exciting. Can we have that electrodes and have a Bluetooth kind of system connected? One good movie is Upgrade. I think we should all, see it out.
Upgrade is a series. I have seen that.
Yeah.
We want it to be done by you. Okay, you can integrate artificial intelligence into our machine. A physician does it. Okay, and it gives a result. What is the problem with that? That is artificial intelligence. You are incorporating into the machine.
Correct.
So we will be very happy. That's when he told that it can be then be used by physicians also. Why a simple problem which can be tackled at a village level by MD person has to come to PJ because that nerve conduction machine is available only in PJ. The main reason why it is available only in PJ, a good machine costs 40 lakhs. Not viable for a doctor. And a simple machine costs at least 4 or 5 lakhs. So if it is available for say 25,000, 30,000, I think peripheral people will also start doing it.
One more thing, sorry I'm taking time. What about the Da Vinci tools, that is the cloud robotics for operation?
We do have robotic tools, we have this. But the issue with that robotic tools is when you have in country like India, where the number of surgeons are, we have a sizable number of surgeons, and you have to use Da Vinci device which is like costing a few crores.
We can replicate easily.
We can replicate it easily,
AI is
but
there
the
now.
fidelity has to be validated because it is a high precision model. And the fidelity, the problem with that replicating a device like Da Vinci or any other robotic surgery devices, this has to undergo rigorous evaluation through any drug approval authority. That we can do easily. Da Vinci is more than, I think, 20 years so old.
No, but I want to say here, sir, there are two types of innovations. One is for common people and a very, very simple innovation, okay, which helps the masses. Second is very high-end and very, very, pointed, okay, will be used at this level. So they are different. We have not presented it here.
Okay.
So machine and cloud interface, what we have presented here is what we see in bulk and what nobody is interested in doing. The most important thing, everybody across the world is interested in preparing a robotic. Everybody. But these simple problems, nobody is interested because they are not going to, they are going to improve the quality of the patient. Like anything, but they are not the problem of Western countries. They are problem of India. So the fecal swelling is no longer a problem in Western countries. They just keep their patient in the hospital. Hospital will take care. They will ring up maybe after 6 months. How is my dad? How is my mom? Here we are taking care of them in the home, daily seeing them suffering with bed sores. So we have, focused at that point. Okay, we want solutions for them. So that artificial intelligence, of course, we did not focus in this presentation, but we can go and on all that cloud interface and everything.
I can connect you with good people. Thank you, doctors.
Any other input from my colleagues? Professor. Yes, Dr. Sujata. Mike.
Thank you. So I just wanted to have some ideas about Dr. Karthik telling that we have all these devices that are there abroad and we're trying to replicate them and try to make it here. So if you talk about devices and the requirement for our people, I'll just take the example of an exoskeleton. One exoskeleton weighs 40 kilograms. So one of the biggest reasons why it is rejected by people is because people just cannot carry the weight around when they do it. So to replicate, like the Jaipur foot came and that was like the very cheap light model of a prosthesis which ended up becoming world famous. So the challenge is not, it's not about doing something completely new which has never been done before, but trying to adapt it to our settings. So replicating it in a lighter model and precision, because if you're using an exoskeleton to tackle weakness of the fingers and stiffness of the fingers, and you're giving him a skeleton that is occupying half his body, it's pointless. So putting it in a frame that suits the Indian people, customizing it, making it lightweight, making it dispersible, that we can break it into different pieces and each part assembling, disassembling, working in an environment where a person can take it to the home across the mud-tracked roads and maintain its usability, that will be the first. As far as AI is concerned, I learned that we don't even have a server for PGI. So let's get a server for PGI first. That's what Dr. Goel was telling, that let us focus on the bare basics and then go on to devices which are like even for talking about rehab for our patients, stroke, epilepsy and all of these basic needs. We do not need unique solutions to that, but just have very simple solutions that is going to cater to the numbers that we have. That's all. Thank you.
I have a question. Yeah.
Yes, please.
I think this works. Thank you for the nice presentation. I have one question related to that truss arrangement for the Parkinson's patient. So I would
It
like
can be
to
used for
find-
any patient, not just Parkinson's,
Okay.
for balance issues.
Just for I was curious to know about whether is it a rigid structure and what are the magnitudes of disturbing forces so that it can be
These are not devices, these are examples. What I am telling you, what we want. So patient of, for example, Parkinson's or any other patients with balance disorder, they have very good power in their lower limbs. Power is normal, they can stand on their own strength. But once they stand, they cannot make balance, they keep on falling. So just like a child, if you see a 1 year or 1.5 year old child can stand upon his feet, but it cannot balance. So we need something like a child walker which you have seen. The child is made into a truss or something, truss or a suspended body in which the child moves his lower legs and moves around without the risk of falling. So in this we are just giving an idea of what is possible. This can be a rigid, this can be a flexible device. You can adjust the arm length, height, the weight, the length of the trusses, everything has to be adjusted because it has to be developed for a large number of patients actually.
Again, for innovators who are listening to us and are online, see, as Karthik has pointed out, the main problem is for a child, you just lift him up and put in the walker. Okay, and he starts moving around enjoying. For an old person, this cannot be done. So we need an innovative idea where a person is lying on bed and it can be converted automatically into a walker kind of thing. But then it should be cheaper also. We have beds now available in ICU which just you press 2 buttons and they adjust as per patient. So in that situation we want innovators to simulate the thing. Like for blind person you can close your eyes, see what all problem you are having in walking and then devise a solution. Something can be put, a camera can be put which keeps on giving signal, okay there is an obstacle in front of you. Like I give an example of a thermometer. See, we have already developed electronic thermometer where temperature comes 98.6, but then patient does not know what does it mean. Everybody will come जी temperature thermometer ने fever दिखाया, कितना दिखाया they don't know. So if we incorporate a sound in that, your temperature is normal, आपको बुखार नहीं है, this will like solve. This is true for India, may not be true for Western. This will solve our problem like anything. So that kind of innovation which is suited to Indian people. We have never used these instruments, sir. We do not have any idea about how these work. What we want is a simple thing where a person can go in very easily without any problem and then he can move around with the help of that purpose. These kind of simple innovation.
I think what you're saying is,
Yeah. Sir, excuse me, sir, ma'am
I
has
just
to
need
leave.
2 minutes. I have
She
to
just
leave.
need 2 minutes, she has to leave.
Okay, my compliments to you. Good morning to one and all who have gathered here, and I can see we have like 2 sorts of teams, from the medical side and from the engineering side. And we have been I am from Department of Science and Technology, and we have been trying to inculcate this culture from very long, and now it has been taken up very seriously by like government at all levels. Niti Aayog is also looking into it, and everywhere like there is a strong focus on bringing engineers and doctors together. My compliments to your team, sir. You have articulated all the problems beautifully. I was totally into it, and I would like to share with you that we are preparing 2047 Viksit Bharat plan, and assistive devices, quality life for elderly is the main focus in that plan. As we all know, being doctors, I think you all are aware the birth rate is going down, and by 2050 it will come down. And now the capital that we have is youth population. By that time, that will be in the bracket of elderly. So we are talking of Viksit Bharat. We have enough money to support ourselves. That is what we foresee. At that time, we will everybody will be above BPL, and everybody will be earning enough to sustain themselves. So we will be having aging population at that time. So right now is a time when we have to think of this kind of assistive devices. We don't see it only as the medical aids. So lot of programs, lot of consultations are going on in the government to look at the devices which can really improve the life of elderly. And in turn, they can be used for the stroke patients, and they can have other medical applications also. As Dr. Saab has beautifully pointed out in the presentation, these are the devices, these are the niche area where we need to make interventions. So from DST side, we are planning to have a MedTech mission also, so where we will be focusing on assistive devices. Even right now, we have a separate program which is looking at technologies for elderly and disabled. So now the technologies for elderly will be our main focus area for another next 5 years. So we will be happy to support any project which really looks to solve the practical problem. So we are not looking at something theoretical which lies in your lab and which becomes a success story for you and which helps you in your promotion and which becomes a personal success. We are not looking at. We are really looking at the intervention which can go to the ground and create some impact on the ground, which the technologies which can be adopted by the people. Even defense is also working with us, and they are also looking for these technologies, exoskeleton especially. Recently they had a big conference in Bangalore, defense engineering wing of DRDO. So, and they were solely, it was focused on exoskeletons. So that is a big challenge, and even from Government of India, we are seriously looking for interventions. And we also plan to, in another 2 to 3 years, we plan to have big innovation centers which will be looking at assistive devices. So at least 3 centers we are planning to have them across the country, and which are working on meaningful translation work which can go to the ground. So India is a country where you need technologies from all the sectors, like you need to serve the people who are from lower income group, and to the highest income group they have access to technologies, they are available in international market as you pointed out, so they can always get it from anywhere. But India is a country where you have industry 0.0 also going parallelly with industry 4 and industry, we are preparing also for industry 5. So we have to cater to the need of all sections of the society. So whatever solution you come up, if it is robust, if it is time tested, and if it can serve the need of the society, so I think there is a huge market. So you have to just identify which segment you want to cater to, and accordingly you can plan your solution. So we are not looking at very high-end solution which are catering to need of the people who have access to international global market. We are looking at the devices and technologies which can really go to grassroots and help our people improve their quality of life. So livelihood, quality of life, these are like major issues. These are like major focus areas for the government. So any intervention in this regard is welcome, and you will be going through the deliberations throughout the day, and I believe something really meaningful will come out of it. So our TEC and this innovation center, so we have another innovation center in PGI only, which is also supported by DSD. So we are looking forward to synergies in all these efforts. So let's come together and bring out the solution which will really make us proud and will be useful for the country. Thank you very much. I take care leave.
Thank you, Nida ma'am. Thank you, Manoj sir and Karthik sir. Haan sir.
I'll just take a minute. Okay, I have some solution or the starting point for the presenters. So when you said like you have a bed, the patient is immobile, he has to go to the bathroom and all those things. Like in the aeroplanes, in the executive class, so you have a bed which becomes a chair, or there's a chair which becomes a bed also. So that component is there. All you got to do is just make it mobile and add your gadgets. That can be started. I'm a professor from the university. So the industry people and the engineering people, that can be the starting point. Thank you.
Thank you, Kali sir. Now I would like to call Sanjay sir for his problem. So this is your pen drive? Hello. Sanjay sir.
PT2024 फोल्डर हो गए। हाँ ये इसमें आज का डेट का ये वाला बस। So very good morning, and thank you for this opportunity to interact with this August gathering. Those are having full of the knowledge and full of ideas. So what I'm going to do is briefly take maybe not more than 7 or 8 minutes, is that all the diabetes or the non-communicable diseases are the most common cause of morbidity and mortality. In last 5 years there is significant increase in the morbidity and mortality. So I think the first and most important target can be the reduce the prevalence itself of the diabetes. For that, what we can do, that is the biggest question, because there is a saying in the Chinese that an average doctor treats the complication, and an intelligent doctor manages the patient, smart doctor actually prevent the disease. So if that concept is there, then the diabetes prevalence is rising like anything, then we have to prevent that. For that, what we can do, that is the question. So that can be answered by our social issues, that can be answered by the medical techniques, that can be answered by the close follow-up and all. Ye slide nahi move kar raha bhaiya. Hello. Slide move nahi kar raha. So for that, what we can do, because sir was talking about the AI, so how AI can be helpful in that, that can be another thing. इससे नहीं चल रहा है? हाँ चल रहा है. So that is just what I was sharing with you in this slide, that the diabetes is one of the most common cause of morbidity and mortality, right? So he is just to explain further, the world land mass is looking like that, and if somebody asks me to make a world diabetes map, then it is like looking like that. All of a sudden these Asian countries are increased in the size, and if we call about the deaths related to diabetes, again the maximum deaths of diabetes are actually happening in our country or the Southeast Asia. So first, anything can have a suggestion to prevent the diabetes. So that is most important one, how we can help. The second is patient, say this is another side, just a brief study which was done in our department in the Chandigarh, and the Chandigarh is known for the city of the most beautiful city and most healthy city, so called. But just for your knowledge, I want to tell you that Chandigarh is actually capital of diabetes in India after Chennai. And in Chandigarh, approximately 600 gardens are there in and around. Still, the diabetes is very, very high, meaning by that we have to look why this condition is so high, why this disease is so high. And then one is prevention, second is complications. So in this hall, whoso doctors are sitting, I am sure they are seeing maximum number of patients of diabetes in their. I am an endocrinologist, of course, I see 80% of diabetes in my clinic, but Dr. Santosh is here, Dr. Bhavita is here, the neurology team is here. I am sure at least 30 to 40% of prescription diabetes are written in their diagnosis. So meaning by that, diabetes is the most common cause of amputation today, most common cause of blindness today. The 80% of coronary artery disease are because of diabetes associated, and maybe stroke is also significant association is there, but not that well proven, at least in stroke. But all other conditions, CKD, the most common cause of chronic kidney disease is diabetes actually. So we have to prevent these complications. So one is to delay, to postpone or to prevent the diabetes, and find out early biomarker. Early biomarker meaning by that, generally if we go by the natural history of hyperglycemia, before blood glucose start rising, approximately 10 years before that there is some abnormality starts that. So can we pick up that time so that we can postpone the diabetes? So that can be another research question that is related to the early diagnosis. Then early biomarker. So people are working like say retinopathy. So I mentioned the most common cause of blindness is diabetes. People are working through the tear film and they are finding out microRNAs, and those microRNA can be an early diagnostic marker. For that we can work on that. Similarly, in the various other disease that can be worked on the early biomarker, and for that I am sure that is biotechnology and the people from the hardcore basic science are going to help in this aspect, right? And similarly for monitoring, and we all know that diabetes is complications are because of the hyperglycemic load, and the hyperglycemic load is because of high blood glucose. So high blood glucose, how we can monitor? Like we can have the glucometers. Though glucometer is very easy, just 800 rupees the instrument is available, some 15 rupees strips is available, and I'm sure you must be aware that some glucometers are, indigenous glucometers are there, but those are not working that well. So that is another important area for the research. Similarly, next step is CGMS, Continuous Glucose Monitoring System. That is already available in our country, that is costing 5,000 rupees, 6,000 rupees for 15 days, and that is very good. Can we replicate, can we reproduce in our, by the indigenous technique that can be used? So that is there. Another thing before going to the next slide, that you were talking about the UPI made by the SBI, right? So in PGI Chandigarh, that is a local problem, that if the patient can pay the money by that some scanning system, because otherwise he has to stand in the line for 1 hour, 2 hours to pay one fees, and suppose he is going to another department and they are asking to pay another fee, then they are facing another problem. So I am sure the PGI is working for that, but right now, as of now I am speaking here, there is no solution for that. So people, those are interested in this area, that can be huge help for the patient, for the doctors, for the hospital burden, everything, and that is can be a very, very important aspect that can be taken care of, right? So now I am coming to the another endocrine disorders, that is the pituitary tumors. Pituitary gland is lying in the brain, center of the brain. If I put my finger like that and go like this, then the third point where these my two fingers are going to meet, there is a pituitary gland. The surgery, pituitary gland tumors are the one of the most common tumors of the central nervous system, of the brain tumors, most common. The pituitary is sitting in that position, it is difficult to reach to that site. So I'll give you a corollary to that, that few years back that scientists from the IMTech, under the guidance of Dr. Sani, Dr. Raj, he made a coronary specific streptokinase, meaning by that streptokinase go and work on that coronary artery, not on the other vessels. Can we make something like that, that the tumor is there and any antidote against that can go and bind to that pituitary area, not to the other area? That can be another good area of research where it can be worked on that. So that is there. Already neurology team given the detailed description, the bowel catheterization of the disposal of stool. I think that is a very, very important area that can be done. So I am not going to talk about that. But if anybody is interested, actually I presented long back when Dr. Chawla was director and they planned something. We have a preliminary model also, that how it can be utilized. So we can talk on that if anybody is interested. The problem coming was the contrary to the urinary bladder, which is a quiescent, usually not having lot of movement, but the bowel is in continuous movement, so it is unable to retain that anything which is foreign body in something like that is one of the problem, but that can be solved, right? So here is the diagram, which is like a type 2 diabetes. If every person sees that different type of diabetes, this all is an advantage that every field specialists are there and they can pitch in one of the problem by targeting the same, right? So I'll end my presentation here, and one more thing I want to tell is that people, those are from the pharmacology background or the pharmacy are there, n number of drugs are there, those patents are over actually, but those drugs are not available in India. And if we ask for those drugs for the treatment of patient, for example, adrenocortical carcinoma, Dr. Santosh is here, for that we use mitoten. The mitoten is nothing but a DD congener, that is what we use for the spraying for the malaria mosquito to kill that. So that drug is available 30-40 years and that drug is very effective for that particular disease, but that drug is not available in India, and we are taking or asking patients are taking from the grey market, and that can be easily make these drugs. So that can be repurposed, or those drugs, those already patent is over, can be made in India. With that, I'll end my presentation. If there is any question or comment, I'll be happy to answer.
Thank you, doctor. My reason for coming here was basically diabetes, and so we are channel partners of Tata Chemicals, and regarding diabetes, we are going to launch a new product on 30th of this April in Press Club, Chandigarh, which is basically a liquid fiber derived from sugar itself. So Tata has a plant in Chennai where they are making this product, and we are going to pack it with some value additions. So this product is going to be a very, it will turn around like anything, because it is a replacement for sugar and honey. So it's a fiber which is a sweet fiber. Okay. So I think this can work very well. One of your doctor, Mr. Patil, he's Amol Patil. So he's working on this, and we are going to meet him today itself. Yeah. So I would like to meet you again for this. To see this. Yeah. So we would we would tie up with PJ also and other institutions to use this product, and we can have a separate session on this. Yeah. Thank you.
Excuse me, somebody is making notes on these things.
So the another important issue, the social issue in the diabetes, is that they sending the mithai ka dibba in every marriage. So I think we should stop that. That is a very, very important problem, because you are sending a mithai ka dibba 1 kg in every occasion, and in house you have 5 kg mithai in one marriage. You eat first day, second day you give to your servant, third day you give to the dibba wala and everyone is getting obese. So we should make this change in our society. It's high time to change that. We should not give sweets as a, what you call, to greet or share your happiness, and rather than you should stop that, and you should, as an innovation, you should find out a idea which can be replaced by the sweet, and that is more healthier. That can be another good idea. So yeah.
We already made the Kaju Katli. This is plant-based sweetener. There is no stevia, no nothing. So the recipe is from Tata.
Okay. Thank you. Thank you.
Thank you, Sanjay sir. Now I would like to invite Dr. Babita from anesthesia. Please, ma'am.
Presentations में टाइटल नहीं आ रहा देखो टाइटल बड़ा इशू आ रहा है मतलब टाइटल दिखाई नहीं दे रहा
Ma'am, please. Yeah. एक
सारे हैं, मैं करती हूँ धीरे धीरे। फुल स्क्रीन, ये
रहने चाहिए बस।
right. Very good morning to all of you. I must express my gratitude to CBiot and the whole of your the industry and engineering team here to present us the innovative ideas, and I'm just presenting few of the problems which according to our previous presenters also, they have presented the problem which is related to the day-to-day patient or quality of life. I would also be presenting something which is affecting the quality of life. As Anita ma'am told that we are very much focusing on to the quality of life as well as affordable healthcare. So focusing on to that, I will be presenting first of my movement. How would we go further? Okay. I don't have any disclosures or conflicts of interest, barring that this is not my normal voice. I have a very hoarse throat and it is actually difficult to speak too much. Also, let me I'll be presenting very briefly 4 or 5 of the problems. As we have been instructed by Dr. Varinder that we have to present problems, not the solutions. Though we do have lot of solutions to our problem, but we are not presenting that. So we are expecting maybe your solution might be better than what we are thinking, because we are neither the engineer nor the IT professional, so you might come up with better ideas. So first thing is that I am an anesthesiologist by profession, and I have taken up a super specialization of chronic pain. So I'll be talking about anesthesia innovations and then the chronic pain innovation. Since the time I have started my anesthesia practice, the one thing which I've been bothered hugely by the anesthesia workstations wire, and we definitely need some solutions. I won't explain too much and won't take much time, only 2 minutes, just to show you a few pictures. This is what our anesthesia workstations with the patient look like. Do we have any pointer? Okay, so according to American Society of Anesthesiologists and Indian Society of Anesthesiologists, there are minimum mandatory monitoring required. Over here, you see the anesthesia workstation. This is the big anesthesia workstations. This is the patient lying, and just imagine lot of wires to the, and this really compromise the safety. Sometimes you have lot of disconnections. We need to change the position. We might have to make the patient prone, sitting, or if we, especially when we have to make the patient prone, then lot of disconnection occurs, and this compromises the safety. So I would say this is my childhood dream since the time I have joined anesthesia practice as a trainee. Since 25 years I've been thinking, can we come up with some solution to this of wired anesthesia workstations to wireless anesthesia workstations. So this is another picture which to show you that how messy the things can become with wired anesthesia workstations, and till date we don't have any solution to it. This is another picture. So what is there, that we have anesthesia workstations, we have ventilator, and we have monitors. Okay, and we have anesthesia gases to be given. So there are many parts, major 3 parts of these. So ventilator, anesthesia monitor, and the delivery of the gases or anesthetic agents. And all this, especially the monitoring system, to meet the minimum mandatory monitoring, we need this wires, ECG electrodes, ECG leads are attached, and then ECG lead cable is attached to the monitor. Similarly, temperature monitor, temperature lead is attached, it is attached to the monitor. Similarly, what we cannot take out from the anesthesia workstation to the patient connection is only one thing, that is this patient tubing. That is the only thing which we have to keep, because we have to ventilate the patient under anesthesia. Except all those other things can be taken out. I do have some ideas, but I'm not presenting those ideas. So this is my first problem to pitch. So if you have any comments, or should I present all my 5 and then discuss? Okay. Sure.
To any problem, if the problem is defined in a very proper way, like this is the basic of the problem, and this is, then the person who's giving a solution, it can be very, I will not say easy, but very comfortable to see. Like you have presented the problem in a very, good way.
Thank you.
I am basically an electronics engineer. We deal with textile industry, but I do innovate in various industries. That is why I am here. Now, in this, I have just 2 questions or 3. One you already answered that what cannot be taken out,
Yes.
to be part, you understand. Rest we have technologies which use or the routing, like the wires I can see are coming from 3-4 different.
3-4 different sites.
Right.
So if the patient is in the center, can we reroute the wires from one side, second side, or the top? That is one question. Second is, if we take out the wires, we have 3-4 technologies which can be Bluetooth, Zigbee, which can be, Wi-Fi, or many things. Today we are very much in the right, time for all the solutions. The problem, if defined very properly in Hindi, English, Punjabi, whatever language, the solution, if not 100%, I think 90% it should be available, and we can be a part of it to not design the solution, but at least to design the application around the problem, because the electronics, the software, the mechanical can be done, but the application has to be decided by somebody like you or us. That's all.
Thank you. May I know your name, please?
Deepak.
Mr. Deepak, I got your question that you are asking whether we can reroute the wires.
Yeah.
Yes, we can reroute, and we have been rerouting, but it is not possible in all the scenarios because surgical trolley comes. Surgeons do laparoscopic procedures. Surgeons do laparoscopic procedures, right? And sometimes the patient has to have both hands down, and we really may not be able to reroute. Coming from the top, yes, we are sending already from top scenarios there for passing the gases tubings. But as far as the monitor tubing goes, rerouting is still not the answer. We can do that, and we are doing that. But if we can take off maximum wires, if not possible all wires, then it is the answer.
That's right. So some, it's a hybrid combination.
Yes.
Something has to be wired depending upon what kind of signals are more critical, what are less critical,
Yes.
how it can be done. So there's a solution. I mean, the possibility is there. Now, a team, of course,
Yeah.
sits and we
Yes.
can all decide,
As-
how to go ahead about it. Yeah.
Fully agreed. As you said that there are basic few things we can do, few things we cannot. Like we have what is known as minimum mandatory monitoring. If we can take out minimum monitoring, which is used in every patient, in practicality, at least we will be off wire for maximum patients. But there are patients who are very sick, for which you need extra monitoring. Those if cannot be taken out, like arterial blood pressure monitoring cannot be taken out, it's okay. But NIBP, non-invasive monitoring, should be taken out, because we will be using, if we perform 1,100 patients surgeries in PGI every day, at least in 1,000 patients we can take off.
That's what I meant. That's what I meant.
Anji.
See, me and Deepak has been working together on textile industries, and so it was a very common problem till now that machines are always surrounded by so many cables and so it is not only the inconvenience, but it is also the magnetic field around those wires which are loose also, so which can hamper, even can affect the patient also. So out of 100, if we can remove 60-70 wires also, it can be. So for this, I did a project in Japan. I was working with Japanese. I went to Toyota factory and Honda factory. See, they call it fugais. It's pointing out all the such irregularities in it. So what I will recommend is to take a project, to take a model project where your patient is surrounded, or that particular machine is surrounded by many wires like this. So we can take up a project like this, and we can make a list of those wires which can be eliminated and can help you in a great way. So we can do this. We can take up this project also.
Thank you. May I know your name, please? Thank you, Mr. Ajay. Thank you.
And one thing more I should say is, since it's your childhood dream, you should do it. That's important. Yeah, that is how it works. That is how it works.
Good morning, ma'am.
Good morning.
Actually, what I was thinking that suppose you are using a projector, and we are not using direct wires, but we are using it via connector. So can we, suppose you have limited number of wires, you put it somewhere in the connector there, route the wires underneath the ground, and take out the connectors underneath your table where the patient is lying. Then those set of wires are only connected to a connector down there only, and not in the middle, so that it doesn't hamper your movement while you are monitoring the patient and all the things. I think that should do it.
That can be thought as a one solution, but there is a problem to it.
Yes,
in operation theatre, we don't have a fixed anesthesia workstation position. It needs to be changed depending on to the type of surgery patient need. So though 60% of the time it is at particular place, like most, but in 40% or maybe 50% of the chances that the anesthesia workstation needs to be also moved. Sometimes it is at foot end, sometimes it is at head end of the patient, sometimes it is on the right side, sometimes it is on the left side.
Then we can have multiple access points for the same. So it won't be an
multiple
issue.
access point would need multiple wiring everywhere.
No, suppose this is a table, and you have connectors here, similar set of connectors, similar set of connectors here, similar set of connectors there, similar set of connectors there, which are all routed underneath tiles on each other.
You are suggesting that whenever we create or make OT,
Yes.
maybe a new modular OT,
Yes.
we can have this.
Yes.
That can be thought of.
Even certain wireless.
There's sometimes the signals are very critical, and there could be a loss.
If 30%, 40% can be.
At least जितना निकाल सकते हैं वायर उतनी निकालते हैं.
Yes.
Okay, ठीक है, done.
Thank you.
So we've got a signal that I think we are short of time a bit. Next. This is, as I said, I'm an anesthesiologist turned to pain physician or taken up. So the next problem to pitch is barriers in providing high value care for chronic low back pain. So as Dr. Badada said, most of us, or maybe 40% of our population has diabetes. Similarly, nearly 60 to 80% of all of you might have experienced low back pain with or without radicular pain, leg pain in your lifespan. And that becomes chronic, and it is one of the very, very prevalent condition, musculoskeletal or neuropathic prevalent condition. And it is not just low back pain, which I'm bothered or we are bothered about. It affects all aspects of life. It leads to years lived with disability disability, very massive amount of years lived with disability. It leads to absenteeism, it leads to mental health affected. So in fact, in Indian scenario, this is the global scenario. It is rated as 4th top position amongst the 10 list in the Lancet commissioning survey, which causes disability more than any other chronic illness. Sorry. So when we come to, India, in Indian scenario, back and neck pain is ranked second leading cause of years lived with disability, only after anemia. Anemia is the topmost, which we all know, and the back and neck pain is the second one. We did our own population-based survey, ICMR funded, Tri-City, and we found that the lifetime prevalence of chronic low back pain was 57%, 1 year prevalence was 48%, point prevalence was 32%, and these patients who had chronic low back pain had significant impact on sleep, depression, psychological problem, and effect on the social life. So what is the management of the chronic low back pain? When we talk about the management algorithm, a biopsychosocial framework should be followed rather than just biomedical. We are not being being a trained chronic pain physician. We must know that we are moving from biomedical, matlab ki doctors are thinking only in giving medication and doing intervention or injection. No, that's not the solution, because chronic low back pain ka major cause is bad ergonomics and bad posture, or the changed lifestyle, lack of physical activity, or sedentary lifestyle. So we need all the first line high value management is non-pharmacological management. I'll talk about what exactly is that. Second line is pharmacological management. Second and line with the adjunct is minimally invasive interventions, which we pain physicians do, and last is surgical intervention required only in 1% of patients, refractory patients. So what is all guidelines, whether it is Indian guideline, European guideline, American guideline, Australian guideline, all emphasize on high value first line management. And what is that? We must educate the patient about what exactly is the disease, how they should be advised about to stay active, how you should sit. I don't know how many of you are sitting properly currently. Nearly 90% of you are not sitting properly. You should exactly give the, knee should be at the level of hip, or your back should be just touching the lumbar area. Nothing else needs to be touching, and this is how you should sit. And this in a busy clinic, advice to stay active should be given, exercises, psychological support. This is first line management, high value management, which is not only in developing country but not followed also in developed country. Why is it so? Why it is so? So this is Akshay. We must explain to the patient about what exactly is the disease. Psychological support should be given, but we talk about that all guidelines say this is the first line management, high value management. Pure Lancet ne pura survey kiya, they said that both in developed country as well as in developing country, this has not been followed well. No, usually the pain physicians do not give an ample time to the patient, explaining them the disease process, explaining them the good ergonomics, explaining that you all are IT professional, how should you be, your computer should be facing at eye level, what should be the level of your hands, what should be the level of wrist. No one gives, this is usually not followed. What on the contrary, what is followed, rather than giving this high value first line management, people follow pharmacological management, start giving epidural steroids. Those do not work in long term. Okay, so what is the issue? That why are we are not being able to deliver? In developing country like ours, high patient load, I see 80 patients in a pain clinic. I possibly cannot give half an hour to each patient. So what I am lucky to have my research officer, I have a DST Satyam project started, so, or I have other non-medical staff who has been trained. I have already created a back care booklet which has been translated in Hindi, English and Punjabi, and I give it to the patient, those 50 pages booklet. But not all of us do follow that. Still, despite I'm doing so much of effort, there is a patient is still not being able to follow or implement it. And there is also that patient may not come to get those non-pharmacological advice, and there is a transportation cost. So what is that? What is the solution? That high value care is not being able to adequately delivered or being implemented. So I am looking for a solution from your side. Yes, thank you.
I think all these questions we can take later on. Dr. Santosh has take OPD.
I think he can present if he has an OPD. I can take it later on because मेरी दो और हैं, no issues. मैं ये वाला करके I will sit. He can present and I will do later on. No issues. No issues, no issues. So अगर ये वाला solution लेके I will ठीक है. बस 2 मिनट.
Solution that I have that I also respectively and most honored person that I'm working with my mentor, right? I don't know, but coming saving time. I'm not a doctor, just a normal guy. My name is Harpreet Singh. I have heard a lot about stem cell treatment, and Dr. David Sinclair is on a generation 4 of CRISPR technology. I think India is the one who can prevent 70% or 60% of the surgeries by using that stem cell treatment and Gen 4 CRISPR technology. CRISPR. I don't want to, validate my word with the wrong definition, but CSI. CRISPR, just blow it. I know what CRISPR. So CRISPR technology in combination with stem cell, we are already on stage generation 4 CRISPR. So the eradication of tumors, just biomarkers, you name it, we are on Gen 4.
I'm sorry, I am not able to. How is it?
Because you wanted to have that solution in which you don't want to have patients doing surgery. Because surgery is main problem, right? If you can increase the number of.
I am asking, there are barriers to deliver non-pharmacological management.
Yeah.
We have tried the conventional way, giving it to the patient body. Okay, this is what we do. Giving the patient a booklet, or still we are not being able to deliver. We are able to deliver nearly 60%, despite our best effort.
I've heard it very clearly. What you've done is the right way. So basically, in your case, you want to save that doctor time and pass it on to your next level people, possibly now.
Yeah, not exactly save the time, but yes, deliver the yes.
So this is very much possible. This can be discussed very well. How? Okay. So as you already said, so basically see how the digital marketing things are happening, right? So this can be done digitally.
Sorry. I think Dr. Santosh and I am going to. You can discuss it.
Thank you, Nobita ma'am. And Dr. Santosh.
I am Dr. Santosh. I am an urologist, professor of urology in PGI. Sex problem and impotence is more devastating than the earthquake and war. And sex is as important as water or food. And I will say that I have saved at least dozen of patients from going for suicide by restoring his sex life. What are the method? If patient is important, there is penis, there is blood flow in the penis, there is 2 chambers in the penis in which blood flow, which make it rigid for penetration, and there is 1 channel in the penis for urination. So there are devices. This is the device which is made by American company. See, this device is very complicated and cost 10 lakh rupees. So 99.9% of Indian population which is suffering from impotence cannot afford this device. And again, surgery is massive. You have to do 3 placing all these devices. You can see this is the reservoir, this is the pump, and this is the tube. Then you are keeping the pump, pumping this, the fluid from reservoir is going inside this. So you have to place the reservoir by the abdominal surgery, you have to place this tube by doing canal surgery, and you have to place the pump in the escota around the chest. So this is very complicated thing. There is another, this is the device, made by American AMS company. Another second device is, this is rigid device. There is metal inside this tube which provide the rigidity. But this is very painful. At least 6 weeks patient has to suffer with pain. This is another rigid device. And this is the extensive surgery. see so mutilating surgery. Just to providing his active sex life, he has to go this mutilating surgery. Just you want your feedback and you provide something on this issue. I have some idea that just putting a tube inside the penis, there is no surgery. He need not to put a pump, not to put a pressure on the pump repeatedly for the erection. You put a tube, hollow tube inside the penis. And just some electricity can expand that metal to pre-formed memory level. If you change the memory, you change the electricity, the memory of metal that will be established or the fluid will be established. This is my idea. That will make the surgery smaller and comfortable the patient. This is my idea. Second thing, this is the bladder. This is the bladder. People have just talked about the diabetes and diabetes associated problem. You are the capital of diabetes. Okay, diabetes pandemic here. So at least out of 100% coming for urinary problem, 1/4 of patient is suffering from diabetes associated failure of the bladder function. This bladder does not contract. So he is not passing urine, he has to be on catheter, lifelong. What is the solution? So we can work on this issue. I have some ideas on this. Coming to the third, urethral stricture. There is a tube inside the penis which gets narrowed due to multiple surgery and due to some inflammation, some infection, which is very common. And you can see there is multiple narrowing inside there is multiple narrow area. This is the present status of road in Chandigarh. Previously used to be very smooth, but now this is the status. So this patient cannot void comfortably. He will urinate with the lots of pain, lots of pressure, and when he void, he will be sweating and very pain and burning micturition. The quality life is worse. These are the various surgery, which is again very complicated. There is endoscopy. You can do surgery with endoscopy. Again, the success rate of endoscopic surgery is very less. If you do open surgery, success rate is around 80 to 90%. It is not 100% in spite of open surgery. But if you do endoscopic surgery, success rate is only 30%. And you can use knife, you can use laser. And this article published by me, we injected some chemicals inside the stricture area. You put some chemicals, these are the chemicals, to prevent recurrence of a stricture. But delivery of all these elements inside the stricture segment was difficult. These again, incidence of stricture is so much, you cannot put all the patients inside the surgery. Our anesthetist friend is here, Dr. Babita is here. They will tell ki so much surgery, oh 4 p.m. close the OT. So you have always fight with Dr. Babita like many friends anesthetists. So accommodating all those patients is very difficult. So you have idea ki patient does not need to go to OT. You can cut the narrow segment and deliver all these chemicals. Again, this was published by me in International Journal. And these chemicals will reduce the recurrence of a stricture. But you have some ideas how to cut the stricture segment and how to deliver all these chemicals inside the diet segment. You have some ideas, you will not discuss it. Thank you.
Any questions? Online also, people are also invited. Thank you. Now I'd like to invite Dr. Bubita, sorry, to continue.
Two and three was worth. So, right, this is what we were discussing. There had been some ideas which were coming up. Another thing, a problem is that though I have some idea, that is what I thought that over here, probably mobile health, mobile app development might help. I'm just suggesting you can come up with many other ideas. Also, we do not have any pain registry in India. Forget about India, neither in North Zone, forget about North Zone, neither in Tri-City, forget about Tri-City, neither in PGI. So maybe if there is some solution to doing or preparing a pain registry. Now moving on to this is not targeting the till now we were targeting the large population patient. This is targeting the teaching of our fellows. We might be starting our chronic pain fellowship, pain medicine fellowship, probably January 2025. So what we do not have X-ray compatible teaching spine model for interventional pain procedure, and we need some solution for that. It is not that these are not available in the market. These are available in the international market, pretty expensive. Each model costs nearly 4 to 8 lakhs. And I think we can afford to create in much, much lesser cost. So these are the moving. Actually, it's not moving. ये इस पे नहीं, स्क्रीन पे मूव नहीं कर रहा, आगे नहीं मूव। इसको भी बंद कर दीजिए, बंद कर दीजिए इसको। प्रॉब्लम 3 हो गई है, प्रॉब्लम 4 बंद कर दिया आपने। I'm sorry. So what do we have? We have spine models. We use X-ray machine, which is known as C-arm fluoroscopic machine. And we do our minimally invasive pain and spine procedures in the patient. To teach our residents or to teach our fellows and trainees, we need spinal models in which the spine is vertebral bodies and disc and the body parts are simulated are there, and that model which is X-ray compatible for the teaching purpose. So these are the models available in the market, and we do have but no Indian model, and these are also not available freely to us. So this is where we use X-ray machine and do the procedure, and we can also do the needling of for the procedure, where the vital needle can be placed. So these are simulator spine models. However, we don't have our own. Then moving on to one of my last one is by my assistant professor, by my another professor, colleague of mine, problem 5. She is not available, she is in Delhi, one of the team member, and I'm presenting on her behalf. USB. She is a neuroanesthesiologist. She is trained in neuroanesthesia. She has come up with the problem of endotracheal tube with inbuilt bite block and subglottic suctioning. So in neuroanesthesia, the patients are posted for very, very long hours. The procedure goes off for at least 10 hours, 12 hours in most of the time. And the patients are kept intubated, the trachea is kept intubated in the postoperative period for some time also, maybe 2 to 3 days, and patients are kept on ventilator. And there are various causes of, so we need to keep the endotracheal tube for a longer time. And this is what usually happens, that from the mouth, if we are keeping the tube for 2 to 3 days, patients might bite the tube, and patients might have also secretions collected in the oropharynx. For that, there are tubes which gives us, there are options which gives us either the bite block or the suction catheter, but we need bite block as well as the suction in the same tube. So that is what is her innovative idea, that though she has designed something, but as we are here to discuss the problem, this is what her design is, which we are not discussing right now. So that is all 5 problems which I had to pitch. Thank you very much.
Thank you, Babita ma'am. Now I would like to call Dr. Akshay. Anybody from online wants to ask anything to Dr. Babita? Please raise your hand. Chat में. सर वो तो यहीं पे भेजा हुआ. So now mic go to Dr. Akshay.
पूरा डेस्क पे सेव किया था डॉक्टर अक्षय को लिख दिया. Screen shared, sir. And who can translate? You will.
Okay, good afternoon, everybody, and thanks to CBAT for having me here. I'm Dr. Akshay, and I'm professor of radiology at PJ Chandigarh, and my area of interest is pediatric radiology. That is what we are going to discuss today, the problems I face as a pediatric radiologist. So just a quick word about pediatric radiology. Pediatric means children, so pediatric radiology is a branch which is dealing with the radiology of the children. So that's the first thing, that we deal with the children. Children have got different issues. They're different from what you see commonly in the adult population. The children are not miniature adults that you just extrapolate your expertise from the adult population into the pediatric setup. They're different. Their problems are different, and it may be like, something like radiation safety, sedation, hypothermia. We'll take it up one by one. Radiation safety is that the children have got rapidly dividing tissues. So you give them the radiation, they become prone to the cancers at a later age. Plus, like, they have a very long life to live. You give radiation to a 60-year-old, he has got another 20 years to live, may not manifest kind of adverse effects of radiation. Talk to a baby who is just kind of 7-8 days of age, has got a CT scan done, has got radiation-induced damage. Now this child has to live another 80 years and can manifest that damage somewhere down the road. So children are sensitive to radiation. We frequently need to sedate them so that they do not move, because our investigations like CT and MR would suffer from motion misregistration artifacts. So what we think is liver may turn out to be the kidney. So that is what requires sedation. And then there are some of the babies, like very young babies, are susceptible to hypothermia, that they can go cold in the radiology department because we maintain the temperature at pretty low level. So these are like some problems which are peculiar to the pediatric population. And the modalities which I am going to discuss today, the radiological modalities which I am dealing with and where I face the problems, are threefold: fluoroscopy, MRI scan and CT scan. You say what is left behind? Well, ultrasound is left behind. That is not something I am discussing today. So let's start with the fluoroscopy. And at this point of time, I want to bring in the concept what is called the stored fluoroscopic images, or the fluorograph. What we do is, we do the like fluoroscopy is like, running a TV, that a continuous relay is running there. So we are in real time looking at the body movements.
Progress.
And at that point of time, we can decide to document a particular frame as a hard copy. In the past, what they would do is, they'll take a proper radiation exposure. Today, what we do is, we just leave the image frozen on the screen and grab it on the hard disk of the computer attached to the machine. So what we do is, we reduce the radiation, and we'll come back to the problem associated with this one. And that problem is that I cannot measure the length. Is that important? Well, it certainly is important, because if there is a narrow segment, what we call the stricture, the treating physician or the surgeon would like to know the length of the particular stricture. And imagine not being able to measure that length. Just because we are trying to minimize the radiation, we cannot measure the length, and we end up saying that short segment, intermediate segment, long segment, or a very long segment of the stricture is seen. So if you can give us a tool which works on a stored fluoroscopic image as a calibrated tool to measure the length, believe me, you are doing a world of good for that baby. Now, one thing which I do not know is that once we are doing these stored fluoroscopic images and are unable to make the measurement, the linear measurement in millimeter or centimeter, we are not measuring angle, we are not measuring circumference, just linear measurement in terms of millimeter or centimeter. Now, whether not being able to do that is specific to the Shimadzu machine which we are using, or it's a universal problem, that is something I am not aware of, because I work only on Shimadzu machine and comment only on that one. So the corollary for this one is, if this is a universal problem, the machines are already installed. You cannot really throw the machine and say that we will provide you the solution in the next machine. So you need to find a solution which is a patch, which is a add-on patch, and it has to be vendor neutral, that it works on Shimadzu, it works on Philips, Siemens, whatever, whichever machine does not provide that facility, it should go in there. And probably the market for such patch would be global. It would not be a local India-based problem. If the problem is systemic in nature, if it is across the vendors, then obviously the machines installed in Europe and America would be the same, and they will face the same problem. Next we'll move to the MRI scan. MRI is magnetic resonance imaging. We have talked about the adverse effect of ionizing radiation on the children, and the main advantage of magnetic resonance imaging is it is devoid of that ionizing radiation, so it is inherently safe for the children. But then there is nothing like a free lunch. It always comes with its own side effects. We need to sedate the child. Typically, a baby would be lying under sedation for 30 minutes, minimum, roughly, in a pediatric body MR, which I usually do. It can extend up to 1 hour. So, there is a need for rapid acquisition of the data so that we can bring down that time from 30 to 60 minutes down to 5 minutes, 7 minutes, 8 minutes. And for that, artificial intelligence probably will step in, enhance the resolution, and cut down on the acquisition time. Motion artifacts. Motion correction, if you have some kind of artificial intelligence which is reading the kind of specific points and correcting the artifacts, there are sequences like propeller and all which I believe are helpful in doing this. So that's another area. You bring down the motion artifacts, you do a world of good for the patient. Hypothermia we already talked about. Now, how it relates to MRI? Well, MRI, the magnet works at a very low temperature. The room temperature by itself is like very low. You put in a unit there, the child will go into hypothermia. So, whether you can acquire that data at the room temperature, if you can do that, advantage, you are not doing the air conditioning. You're saving electricity, you're saving the money, you're environment friendly over there. You can acquire the data at the room temperature, and you can help the child by not running the risk of hypothermia. That is where the main crux of the matter lies. And I believe there's something called room temperature susceptimetry, which some people, I think GE team in the past has been looking at the room temperature susceptimetry, but somehow that did not really take off. There is something we call dynamic scanning for the focal lesions. If there is a kind of a tumor sitting inside the liver, let's talk about only focal hepatic lesions or the focal lesions in the liver. That there a small marble size or a table tennis ball size tumor lying inside the liver of a 7-day baby, 1 month old baby, 1 year old baby, and you need to characterize it. So for that characterization by MRI, we need what we call the dynamic scan. For dynamic scan, the facility is available in the adult population, but then the child is not a miniature adult. You can ask an adult, please hold the breath. You cannot tell it to 7-day-old baby. You tell them, hold the breath, the child will keep crying. So that is where the need for dynamic scanning of the liver gets kind of lost, the requirement gets lost. So we do make some via media, but if we have such rapid sequences which can catch the arterial phase at say 15 seconds and portal venous phase at 70 seconds, if we can catch these two phases, delayed phase is not so much of a problem. The challenges we will face over here are the speed which you are acquiring the data and a baby who is lying completely still. You have to be that fast so that you do not end up in the artifact. Image quality has to be of paramount importance. You cannot evaluate an image which is full of artifacts. The other thing I wanted to say was that there is something called thalassemia. I'm sure people would have heard of it. It's a kind of disease which is fairly prevalent in North India. It is a problem with the formation of the hemoglobin. The treatment is blood transfusion. That blood transfusion leads to storage of iron in the body parts like the liver, the pancreas, the heart over a period of time. So we need to measure that iron on a regular basis to prescribe treatment, and that currently is available only on 1.5 Tesla machine. If you can have it on the 3 Tesla, the advantage would be that the centers who are installing 3 Tesla machine, they can use the same particular kind of facility for the patient. May not be a difficult thing, because essentially you are just developing an algorithm or a computation based derivation that if the signal is this much, the liver iron content is this much. If the signal is this much, the iron content of the pancreas is this much. That is what needs to be developed for our indigenous population. Last but not the least, CT scan. And this is the modality which has been the villain of the story for the last quarter of a century almost. It is a very high radiation dose. You ask me the advantage is what takes 1 hour in MRI will take less than 1 minute in CT scan. That is the speed with which the helical scanner do it. You blink an eyelid, the scan is over. But then again, there is no free lunch. There's a lot of radiation involved. So your hands are tied up at your back while you're going to fight the battle. You're trying to diagnose something, but you're not allowed to give the radiation. So the alternative is to have technology which gives minimum possible radiation, or what we call as the LRR principle, as low as reasonably achievable. Is there something in the market? Yes, there certainly is something in the market which is called the photon counting CT. The photon counting CT is a technology which at present probably is indigenous to Siemens. But it brings down the radiation dose substantially, and like some people say that now the concept is don't do the CT from there, do the CT. No CT to do CT. Now, whether we can have some parallel technology, because the machines are utterly expensive at this point of time. If you want to have such low radiation dose CT scanners across the length and the breadth of the country, you got to find a solution to beat that cost. With that, I rest my case. Thank you. Questions, if any, I'll be happy to answer. Yes, please. Please introduce yourself first. Yeah. You are a data scientist at?
University, US.
Okay.
And so you wanted, your goal is to minimize radiation actually.
Yes.
In all the cases, because it all comes down to minimize the radiation.
Absolutely.
And in the first case, I am no doctor, so I cannot use that terminology, but I listened stricture length when the frames are moving. So we can work on that actually with the help of artificial intelligence. It is very easy to measure the length of the structure so that you can have minimal radiation on the children.
Lovely.
Right?
So we can transfer these images on a DICOM platform. That's not a problem. But on a DICOM platform, we are unable to measure the length. Looks very simple, but then it's a genuine problem.
But we will not order a new machine. We will integrate that stuff patch,
right,
on the current machine,
right,
so that can measure that length. It is the algorithms are very powerful.
We'll be happy to collaborate with you and run a research project straight away.
You're most welcome. Anything related to biomedical imaging, already I'm doing something on the biomedical imaging for US clients, so they're happy with the updates. So for example, we're doing something with the help of thermal camera to avoid duplex in CVI problem, right? So we have a duplex, we have a thermal camera which can take up the temperature from the different part of the thighs and all that stuff, and we can play with the pattern of the temperature to calculate if the person has a swelling or a venous problem, any insufficiency problem. So anything related to venous insufficiency we can do with the camera.
You are putting up in India, or you're you have flown in for this particular conference?
I'm from India. Actually, I have my own IT company, and I'm doing most of the stuff in AI and ML.
We'll be happy to collaborate.
Yes, thank you. Okay.
Yes, sir.
Anybody else? Anybody from online can speak? Chat, thank you. Thank you, sir. Thank you very much, Ashu, sir. Actually, thank you, sir. Now I would request Dr. Shalini Giridhar. She'll be presenting her problem online. Shalini ma'am, can you hear us?
Yes, I can hear you. Please allow me to share my screen.
Ma'am, please, you can share your screen, please.
I think there's a problem. I'll just go back. Yeah. Can you see my presentation?
Ma'am, not yet.
Are you able to see presentation?
Not yet, ma'am.
Yes. Can you see now?
Yes, ma'am. Now it is visible.
So I'll just go back. Yeah. So I'm going to talk about. I'm Dr. Shalini Giridhar, and I'm professor in Department of Gynecology. And I'm going to talk about a handheld colposcope, which is a cervical cancer screening tool. So this is an idea by Dr. Varinder Garg, who has promoted me to present this PowerPoint. So recently we had this on the 31st of March. This was the headlines that PM Modi tells Bill Gates that we will be focusing on screening of cervical cancer, and research funds will be allotted for this. This will be the more on vaccination and everything. And this is by the Georgia University of Global Health, that they talked about that cervical cancer has a burden in the Indian territory, and mobile smartphone based platform allows the physician, and probably some imaging technique would help in managing and targeting the population suffering from cervical cancer. Now, this is another publication of Times of India where this is by the author was Fawzia Khan, Member of Parliament, Rajya Sabha, that yes, million of women in India are left at risk of the disease, and India is committed to achieve cervical cancer elimination, and we'll be focusing on cervical cancer screening and testing. So what is our aim? Our aim is to find a cost-effective, user-friendly, which can be made with the use of technical skills which are already available, and to promote a Make in India concept. This brings in the idea of making a portable indigenous colposcope, keeping all requirements in mind. Now, what colposcope does, we have to understand what it's doing. It takes images of the cervix. Cervix is the mouth of the uterus. So it takes the images of the cervix, while the cervix is visualized through the vagina using a speculum. Now, speculum is something which retracts, which pushes the walls of the vagina so that the cervix can be visualized. The image of cervix which is taken is magnified with a good quality imaging, and for this a good imaging system is needed. Then there are some filters which are used to enhance, and the vascularity of the cervix, that is the blood vessels, are illuminated so that we can see. The images are displayed on the monitor, and the report is given on the computer for the physician's opinion. So what the innovation and application of this knowledge is, we can use this for mass screening in the field, especially in the remote areas, where the trained paramedics like the nurse, midwives can be trained, and some mobile imaging system can be formed so that we take the images, and these are these are analyzed. Now, if you look at the publication of our PM Modi with Bill Gates, he had stressed on AI-based technologies. So the image would be analyzed by an AI-based app to generate an opinion. So an opinion would be formed, and that would, it would be normal report or suspicious or needs referral. So some images can be, formulated on that. An opinion would be formulated for referral versus continued surveillance. The images would be then shared with the program in charge or the specialist, and a pathway of further management would be made. So what we need is, we need a speculum with attached fiber optic light source which can be used for visualizing the cervix. Now this is already patented, which I could see. So the speculum can, although it can be still pre-designed at a low cost in India, and we need a smartphone with a good camera and magnification which can be held near the external genitalia, and so that an image can be taken and captured. With the indigenous phone-based app can be designed, or a new form of colposcope can be made, which is handy and easy to carry, and it is cost-effective. So this is what already exists. This is probably Africa based. This is EVA system where they are already having this design, and but the cost is very high, and we can think of something which is Make in India, and use a similar concept. Now this is in the image. I can show how the lady is placed and how the colposcope, the actual colposcope, is used, and there is a speculum which is there in the corner of my slide, where the fiber optic light is attached. So colposcope specification, this I have copied from the UNICEF UNICEF promoted colposcope, which they are selling at a good amount of price. So the full spectrum visible light with LED source delivering, these are the specification. The color rendering index more than 93%. The optical magnification can be 12x and up to 40x. The adjustable illumination, which is able to focus, zoom. So these are all very possible things in the mobile app. Then equipped with green light filters, which is of course that can be done by our IIT team. The unit comes with this. The UNICEF model is having a phone along with this, which is used as a monitor. But we plan something on the phone. So this is the one model which is of the UNICEF. The colposcope. The colposcope uses additional mobile phone for imaging, and you can see the price. It is $2,050 US. So So what is the need to develop a mobile phone with camera which has the specification of a colposcope, AI-enabled interpretation of the image analysis, and maybe an application with attachment on the smartphone? So this is a simple thing which we have in mind. Any questions? I'm ready to take.
Thank you, Shalini ma'am. Any questions? Thank you, Shalini ma'am.
Okay, fine.
Now I would like to request Dr. Girija and her teammate, please. Shalini ma'am, can you please stop your screen? Yeah.
Hello.
Hello. Yes.
Yeah, actually, I do have a prototype of this device which Madam just talked about. So we would love to kind of provide that because we have been able to
kind of achieve the magnification, the filters, the connectivity, and it has a basic ML functionality. But if we can get some more data and work on the AI part, I think we would have the solution in place pretty much in no time.
That's a good thing to hear, sir. We would like to collaborate and formulate some maybe the chatbots or the AI-based answers to the images and work on that.
No, absolutely. That would be wonderful. And we have also worked on the kind of stand piece because I understand that one, of course, the portability, but if you want to do both see and treat, then we have been able to achieve a kind of 30 centimeter distance and do that. So we have two versions that we're working on currently, and if you can guide us on the, the analysis part in terms of how we can do that beyond the VIA or the aesthetic as a kind of all of it be a great help. I think that we can have the version kind of delivered to you and to the country in no time.
Okay, perfect, sir.
Thanks so much.
Yes, the government is actually focusing a lot on that, and so we would really be boosted for that.
So I'm just sharing my email ID, but I would would love to know the next steps here.
Okay, sir.
Thank you, Niklesh ji, and thank you, Shalini ma'am. Now I would like to invite Dr. Girija Shankar and her colleague Dr. Tanvi for their presentation, please. Sharing my screen. Please.
Good afternoon, everyone. I am Dr. Girija Shankar Mohanty, Assistant Professor in Gynae Department. She is my colleague from Gynae Department. And beautifully, my senior professor Shalini ma'am told everything about the cancer cervix. And we have come up with some idea that we have noticed in our OPD, most of the time patient reach to us in the late stage. In late stage means it is not in an operable stage. More than 60% patient come to our OPD is in advanced stage where we cannot do a surgery. So out of many factors that we'll discuss now, because of some issue they don't turn up to the OPD, they come to the, once they come to the OPD they're in the advanced stage, so that the treatment modality changes after that. So if you see the background in developing countries like India, the cervical cancer remains the leading gynecological cancer, and it has a population of approximately 436 million women aged more than 15 years and older who are the risk of developing cancer cervix. In India, the cervical cancer is the second most common cancer among the women of 15 to 45 as per the National Health Portal. So incidence, as you know, it is approximately 1.3 lakhs cases of cervical cancer that occur in every year in India, and annually more than 77,000 Indian women die because of this disease. By 2025, the number of new cervical cancer cases in India is projected to be more than 2 lakh. So according to the IECR estimate, mortality from the cervical cancer is expected to witness a 79% increase from 74,000 deaths in 2002 to approximately 1,32,000 deaths by 2025. So this is as per a recent 2022 paper. Most of the participants, as per this study, they approximately 95% of patient present at late stage, only 4.8% patient present in the early stage, that is a surgically treatable stage. So we will still present the problem statement.
So the major problem faced in detecting female gynecological cancer in India are ignorance of symptoms, shyness, lack of health infrastructure to detect the disease in early stages, and affordability. The social taboo that is associated with women visiting the gynecologist or the hospital for their gynecological problems is still very, very prevalent in our society, and that might be the major reason why cervical cancer is being detected so late in staging. So we are already having the screening programs available for detection of this cancer. We are not having screening programs for other gynecological cancer, but still we can see the increase in the incidence year by year in this cancer. So the idea is to It's not moving. So already there are invasive methods for the detection and screening programs like pap smear and LBC and visual inspection of cervix with acetic acid. All these programs require the lady to be present in the hospital. So the idea is to develop a new non-invasive method, for example, a home-based kit for early screening of gynecological cancer, just like a pregnancy kit or something. Already there are there is research of de novo proteomics-based body fluid biomarkers in process. And a review has been published by Mukherjee et al. From IIT Bombay also. So we can, what we can do is we can try and incorporate those proteomics-based biomarkers in a kit, and the fluids used in those are cervicovaginal fluids, urine, and menstrual blood. Thank you.
So basically, just the way we detect pregnancy, suppose someone misses her period and she does the UPD test at home, and once his pregnancy comes to the hospital for the further management. Similarly, we are thinking to develop a kit that will indicate the lady that, okay, I am having some kind of problem, so I should, this cervical cancer development takes more than 5 years from early stage to, let's say, we have a 5 years gap to address this problem. Suppose we will detect an early stage of the disease, we can reduce the burden of the cancer in India and mortality related to it. Thank you. Any question? Yes, ma'am.
Because this is actually a real problem when we are talking of cervical cancer and when we are talking about the...
Thank you. So, like Dr. Shalini also presented that some sort of a thing which can go to the lower resource deficient settings where, you know, mass of the women can be, you know, explored for the screening, and you're talking of the the kit sort of a thing which is there. I think this is actually need of the hour. We should be coming out with that. And I would also like to say that if there are certain colposcopes which are available in the market. I don't know what is the kind of a budget they seek or what is the kind of amount they seek. But in such cases, if PGI can come, and we being from the council, then we also have a larger pockets in the rural areas of Punjab where the trials of such colposcope or the kits can be done, and we can also, you know, collaborate with you for the development of this kit if somebody is interested for some sort of a funding and all, and for the field trial it can go for the rural settings from our side. Thank you.
Okay, ma'am. Thank you, ma'am. Yeah, there no some in PGI also some department has come up with this testing the serum from blood sample, but for that reason also patient has to come to the hospital. So we are thinking of just like a simple test, home-based test. The patient can do it as for the leisure and liberty. The privacy will be maintained. Once the it's going on, sir. Yes, yeah, it's going on, but still it's not validated.
Thank you.
Thank you very much. Now, I would like to invite Dr. Praveen with the presentation. अभी दिया इसमें देख लेता हूँ, मेरे को भी यही देख रहा है प्रेजेंटेशन. ये क्या है सर? नहीं डाली है. Just let me just check. मैं आपको next बुलाऊँ. Now say there is some technical issues. Now I would like to invite Dr. Vikas, please. Thank you, sir.
Good afternoon, everyone. I am Dr. Vikas Bhatia. I work in section of neuroimaging and neurointervention. So basically, I deal with interventions which are vascular interventions involving the brain, mainly the aneurysm, stroke, and all this. So I have a very common problem which actually requires a simple solution, but I think it has not yet been addressed. What I want to tell you, many of you must be having a medical knowledge, but angiography is a very common procedure which is done in all the hospitals, and I think Delhi at least 100 200 are done in PGI only, so you can see the burden. So most of them in neuro, actually they are done through the femoral artery, which is here. So when you do intervention from a femoral artery, the patient has to lie down for at least 8 to 12 hours in the hospital, and that will add to the cost because the patient has to take a bed, and simultaneously their attendants have to stay, so it is also a cost burden. And because the patient has to lie down for 8 to 12 hours and he cannot move, so he has to either get catheterized or either he has a back pain because of prolonged lying on a stretcher. So instead of that, if we go with a radial artery access, which most of the cardiology have done, and for neurointervention it is upcoming for last 5 to 6 years, and for last 4 years I am doing through radial artery only. So the advantages are that the patient can be discharged within 1 hour for the simple diagnostic procedures, and no specific tests are done, and the risk of potential bleed which can happen femoral is also low. But the problem with radial artery is it is very small. It is 1.5 to 2.1 mm. in size as compared to the femoral artery, which is around 1.5 centimeters. So you can just imagine. So this artery frequently goes into spasm, and the risk factors are patients who are either female, young, or who have small arteries. So what we do here is, I will just show you that we have this radial type of sheath, as you can see, which is inserted. So till now, what the methods to prevent this spasm are: either you use a cocktail of drugs, many combinations are there, which can be verapamil or nitroglycerin, you use a combination, or you use a specific sheaths which are glide coated sheaths, which have been shown that they can reduce spasm, but still for many cases there are still no good answers. So my research question is here that can we predict the risk of spasm in the radial artery prior to the procedure based on some imaging, or just after the sheath is put, can we predict that which of the patients can undergo spasm? Secondly, can we develop specific hardware which may have specific coating that risk of spasm can be reduced in these arteries, because that can significantly reduce the cost burden and the patient comfort. And third, whether when the sheath is inserted in the artery, can we have a continuous monitoring which can tell us about the pressure inside the artery, that this artery is undergoing spasm. So here I'm just showing you one example. I don't know if you can see the cursor. So this is the angiographic run. This is the sheath inserted. This is the angiographic run, and this patient experienced a significant pain, and you can see the artery has gone into spasm. You can see that it has significantly narrowed. So it happens in very few cases, but still it is quite burdening to the patient. So we want specific hardware which reduce this because of some coating, or which can tell us that after insertion sheath whether this patient is bound to undergo a spasm, so that we can give additional pre-medication. Second is the radial artery occlusion. Now again, it is to hardware related only, seen in around 1 to 5% cases. Mostly it is asymptomatic, but the artery goes. So sometimes there is ischemia, but to perform a repeat angiography from here, again it can be bothersome. So again, so to do a closure in these type of arteries, this is just a case which I did. So you can see very less frequently, but this after 15 days of the procedure, there was significant occlusion of this artery. He had some pain, we gave some analgesics and it subsided, but this artery is not suitable for use again. So this is the type of band which is used. This is a TR band which is used to compress the artery after the compression. So the research question is whether we can do any modification in this radial band so that it can predict and do a graded compression, so that we should know that when the hemostasis is achieved. And secondly, ability to know that hemostasis is achieved, that's the same thing only. So I want a monitoring on this band only, so that the risk of occlusion is less in these cases. Thank you very much.
Any questions? Online? Please raise hands.
Variables have to be known.
Yes, sir. So actually, once we put a sheath, we have a arterial access. We can have all the BP as well as pressure. So we need to know what is happening inside the artery. Because we put a run, it will show us the vessel. But the spasm is something we should know that it is actually causing a pressure, or artery is constricting. We need to get that manometric
That can be
volume.
differentiated, I mean, what that particular.
Yes, yes. Or a coated sheath maybe, some type of coating that prevents the spasm. I have few ideas, but it is just to pitch to you. So already a hydrophilic coating sheath by Terumo is already there in market, but it is not preventing in all the cases. So maybe certain drug coated which can prevent the spasm. Maybe the cocktail which we use can be coated on the sheath. These are some of the ideas. Rest you can. Thank you.
No, please. Thank you, Dr. Vikas. And now I would like to invite Dr. Praveen.
Hello. Good afternoon, everyone. I am assistant professor in Department of Hematopathology, PGI, and my problem statement is manual harvesting in karyotyping or fish processing. Now, most of the institutes, tertiary care institutes, do fish and karyotyping as a routine for malignancies, and what I am talking about today is specifically for hematological malignancies. So the problem is of manual harvesting, the process that is done for fish processing. It is manually done. It is an important initial step leading to generation of a cell pellet and fixation of cells, which is further subjected to processing by fish technique. Now, peripheral blood or bone marrow both can be utilized for harvesting, and the sample can be used for fish or karyotyping technique. Now, these are the steps that are involved in sample harvesting. The sample is mixed with RPMI centrifuge. It is incubated, the cell pellet is dislodged. It is incubated for 20 minutes. We put in carnoise fixative and wash it multiple times until we get a clear pellet like this. So all this process is manual and it is time consuming. We get inconsistent results every time. The person who is doing the manual processing changes or goes on leave every time there is a problem in the quality of the cell pellet that we are getting. So this is a simple process, I think, which can be automated. That is the solution we are looking for. Currently, I'm not sure there are sample preps machine for other processing techniques, not specifically for fish. We can utilize some automated methods for simplifying this procedure and create an automatic workflow for getting a good cell pellet that can be utilized for fish and karyotyping. Thank you. That's all.
Any questions regarding the
challenge?
It has to be automated.
Yes.
Definitely, hardware,
Soft.
a lot of automation is already happening.
Yes, sir.
We work with a lot of machine. What is the challenge?
There is no specific machine that is available for pre-processing of fish samples. So we can develop a hardware and software incorporation which can be used for fish and karyotyping processing. That is we are looking for a specific machine which is used for this specific purpose. There are machines which take care of processing of flow cytometry, processing of other samples, but for fish karyotyping, because there are some additional reagents in fish and karyotyping, we can insert them and the process can be automated, dedicated for this technology. So that individual labs which are doing this test can utilize this equipment. The help is needed for building up an equipment and integrating with software, hardware things. The lab support and the quality control, everything we are ready to provide.
And the outcome you want is basically to save time or quality or both?
Both. It will be significant. Whenever we see in a lab, whenever things are getting automated to a good extent, we see perfect results. There is significant reduction in manual processing time. Quality of results are very good, and and it is all automated, so we never intervene in between. So that is what we are looking into.
It's a simple, you have said different processes.
Yes.
All the processes need a different machine or single machine?
Single machine can do everything. It's within the machine, everything. Yeah, should be able to do. Centrifugation, adding, washing it, preparing a cell pellet, everything should be able to do within a machine. It should be possible. Thank you so much. Thank you.
Thank you very much, Praveen ji. Now I would like Dr. Ravikant Singh from Apex College Hospital, Rewari. He will be presenting his presentation online. Ravi sir, can you hear us?
I can hear you. Thank you so much.
I don't have a presentation, but I have I mean to say idea of innovation to of course present you.
And
I am a EMT surgeon in private practice, not a government setup. I do my own bit. Is my screen sharing visible?
This is binoculars to telescopes?
No.
This is, I have changed that.
I've
I've changed that.
You have changed that.
First,
It starts with my name, something like that.
Is it
Is it visible?
Not yet, sir.
Okay.
Okay, let me do it again. Stop share. Share.
Is it
Is it now visible?
Yeah.
Yeah.
Dr. R.K. Singh. Yes, sir. Now this is visible.
Yes, sir.
Yes, sir. My name is Dr. R.K. Singh and I will be practicing as a ENT surgeon. I work in a trauma center of mine and of course the highway proximity trauma center, a location which is like 70 kilometers from Delhi and it's a NH8 Delhi Jaipur highway and we have a population which is actually low to middle class at our place and we have a lot of villages where they lack literacy and they have fear about their health-related issues. What I cannot, I would. And I just need to develop an ecosystem. I have a small ecosystem already, of course, happening at my place. And I just want to develop an ecosystem for early diagnosis of ENT, like ear, nose, throat related disease in neonates, children, elderly, adults of the rural population to develop a database. I should have the patient data, the patient, the doctor, and the nearby urban healthcare facility and one platform guide them for any kind of medical or surgical intervention. And I have three like innovations for this, which I am actually running on, and I am on like a mobile healthcare clinics. I am into community healthcare worker training programs, and again we have a telemedicine platform and report monitoring devices which are actually on at a very near level as per my financial constraints are. Now let us start with the mobile health clinics. We have a logistic equipment, we have an ambulance which is actually retrofit with mobile healthcare clinics, equipped with basic ENT examination, telescope, like otoscope, nasal endoscope, mobile camera enabled endoscopes, audiometers, and we have installed the telemedicine facility including video conferencing and equipment and internet connectivity for remote consultations. We do scheduling and planning as our, in different villages depending on the population density, the accessibility and the healthcare needs while we plan our routes. We have to do healthcare staffing, recruit trained healthcare professionals such as nurses, physician assistants at our place and overall community health workers to staff these mobile clinics. We perform their patient screening and consultation and conduct preliminary examination as regard to ENT conditions. The common ENT conditions like infections of the ear, external middle, sinusitis, hearing loss, and this is done by a questionnaire form and an on-site video capture for endoscopic image of ear, nose and throat and on-site hearing assessment through an audiometer kept over there. We have to facilitate telemedicine consultation with our ENT specialists in the urban center where we are for more complex cases and their treatment planning. Second idea is, of course, we are now working on is community health worker training program, and then for our participation in them, we provide training to this local community health worker who are interested in healthcare and who are willing to serve as health educators, and we provide comprehensive training on ENT diseases, how to use the equipment, how to assess the symptoms, their prevention and the basic clinic techniques. We also organize awareness campaigns in villages to educate residents about the common ENT diseases, their cause, prevention and method. we have to really distribute some educational materials with journal work because of the literacy. We have some audio visual like videos to in the local language, in the Haryanvi language where I of course come from, and explain about their ENT health and disease part. We have a kind of a screening and a referral services to we do basic screening camps such as hearing test, endoscopic examinations of the ear, nose, throat, and we have established referral pathway to the local healthcare facility. We work in union with the NGOs and which of course help them in organizing the camp, and we send them for further evaluation to the urban care center. We have organized training sessions and workshops for the community health worker at our place to develop and promote them to engage in such programs and to do this kind of an app filling which we have in our software system of the hospital. And the third, which would be the telemedicine, I have talked, we have to find a user-friendly telemedicine platform. Of course, they are very cheap now, very easily available, and we have to design ENT consultations in that. We have to secure kind of a video conferencing. We have to have this electronic health record. Integration, image and video sharing capabilities, and we have to ensure compatibility with the mobile devices as well, because they are the ready handy devices available with everybody. With also limited internet connectivity, also they work very good. And we have to employ a remote monitoring device. We have to explore partnership with medical device company to integrate remote monitoring device. We have a lot of companies right now, and our ENT devices such as hearing aids and manometers, this kind of e-audiometry and endoscopy are now in vogue. Definitely they are working very good. Only thing is to compile all these platforms together to have a database for the hospital, the ENT specialist, which of course is available to the patient as well as to the community health worker. Now, the last thing would be like the patient and provider education has to be must, because patient should at least understand what is really going on and how it is to them, because they have relative fear in them, but that's what this is all about. So we have to do some kind of a patient and provider education. And lastly, the data security. We have to have this patient data security as per the regulations of health insurance, portability and accountability and local data protection laws. And we have to encrypt all the communications and secure authentication methods, establish access control to safeguard and these sensitive information, because they are the patient's personal information. And by implementing these strategies, we can establish a comprehensive ecosystem for early diagnosis and management of ENT diseases in rural population, leveraging this mobile clinics. And we like establish mobile clinic. I am telling mobile clinic, they can be installed for one test or another when the work is over, but they are like established mobile clinic over a period of time, like 1 month, 2 months, until the whole population is screened. We have to work with the community health worker, the local villager who is who has a passion for to be an health education, partly educated, and a telemedicine platform and a remote monitoring device to improve the access to healthcare service and facility for timely intervention. I am asking support to develop this ecosystem. Of course, we have a partial ecosystem still working, but I want to extend it to all the villages in about say 100 kilometers nearly where I live, and that is the support I want to ask. Thank you so much.
Thank you very much, Dr. Ravikant. Any questions online? Thank you, Ravi sir. I request you to stop sharing your screen, please. Now I would request Dr. Padmanathan from Vellore Medical College. He'll be also joining online with his problem. Padmanabhan sir, can you hear us?
Yes, sir.
Yes, sir.
Yes, sir. So good afternoon, sir. Sir, can you please
Good afternoon.
share your screen?
Sir, can you put the WhatsApp images which I sent to you, sir? I don't have a formal presentation.
Pardon, sir?
I have
I have
sent
sent you
you two WhatsApp
WhatsApp
images.
images.
Can you?
Can you put?
To me?
Yes, sir.
Yes, sir.
I'll just look in it.
Yeah,
It's that.
This one?
That
That
ultrasound
ultrasound
images.
images.
This, sir? Okay, just hold on, sir. I'll share my screen first.
Yes, sir.
Yes, sir.
This one.
This one.
Okay.
Sir,
Sir, can you go to the next one,
sir?
sir? Next image.
Next, please. Next.
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 The last
The
one.
last one.
Yeah.
Yeah.
Basically,
I'm
I'm
a
a surgeon.
surgeon.
I'm an
I'm an
associate
associate
professor of
professor of
surgery
surgery
in
in
Vellore
Vellore
Medical
Medical
College.
College.
And I have done my advanced programming in digital image and digital
Digital
health
health
and
and
image
image
from
from
IASC.
IASC.
I
I
want
want
to
to
share my
share my
thoughts on
thoughts on
this
this
ultrasound
ultrasound
machine.
machine.
Actually, when you
Actually,
see
when you
this
see this
ultrasound machine,
ultrasound
it will
machine,
be
it will be
big
big.
and there will be lot of wires connected. If it has to be taken to an ICU or anywhere where a small procedure is being done, it's very difficult for us to take this thing. For that, so next one, sir. Next image.
These are three images we have.
Yeah, next. Yeah. For that, we have options like this is a very small handy, this handy ultrasound transducer, which is available in market. But my specific concern is, you can see in this particular image that there is a two image coming. Above one is a longitudinal image and below one is a cross-sectional image. In most of the machines, it will be a separately visible. It's not live, both of them live at a particular time. But in this particular company, if I allow to tell the name, it's Butterfly IQ. They have a biplanar imaging. This image will be there, but it is a wired platform. So is it possible for us to have a wireless platform with this biplanar imaging, which will be very helpful in like giving anesthesia for pain or cannulating vein for laser procedures or many different applications we can use it. So far, to my knowledge, we don't have any this wireless transducer with this biplanar imaging. Is it possible? That's my concern, and I'll take up questions if there is any.
Thank you, sir. Any questions? Thank you, Padmanabhan sir. If there are queries, we'll let you know soon.
Thank you, sir.
Thank you, sir.
Thank you, sir. Now I request Dr. Surinder Rana from PGIMAR. He will also joining online. Dr. Surinder sir, are you there? Surinder sir. Meanwhile, while we get in touch with Surinder ji, I would like to invite Dr. Astha Nayak from Paro Institute. If you can present it. Hello.
Hi.
Dr. Astha, we can hear you.
Yeah. Give me a second. I'll just turn on my video. Hi, hello everyone. Myself, I'm Dr. Astha Naik. I'm from Parur University, Gujarat, Vadodara. Uh, I don't have a presentation to present here, but I'm gonna pitch about my problem statement. It's on cancer care. Am I audible?
Yes.
Yeah.
You are
Okay.
audible.
Sorry. So, my problem statement is that we have cancer patients around us. There are solutions out in the market who are supporting these patients in their nutrition, rehabilitation, and overall care. But after the cancer, after the treatment is over, there are huge number of patients who have no idea how to go ahead with their lifestyles. Uh, that's like survivorship care. As in India, we have programs run on by government of India who helps these patients with their uh, afterlife. But I think uh, having something more kind of like privatized would be very much helpful, because all of these programs have no sense with personalized or patient centered care. It's based on it's very generalized for everyone. For example, if there is a breast cancer patient, the treatment plan and the aftercare rehabilitation services same for that. So having something more patient oriented uh, would be a need of the market. So that's my problem statement, and I'm already currently working on that. I had a uh, yeah, I'm kind of developing a solution where I'm bringing all of the caregivers into a platform, and they can provide their expert advices and consultations to this survivors, and see how their follow-up plan would be like, and what is the uh, what is the percentage or the quality of the care they're receiving, and its impact on their quality of life, their mortality, morbidity ratios, and so on. uh, I'll be okay if there's any questions around this, and I'll be happy to answer them. I'm looking for uh, at this particular event, I'm looking for persons who would be interested in joining in this kind of initiative. And yeah, that's all. Thank you.
Any questions on this? Uh,
I can be
Online you
contacted
can raise hand.
by.
Pardon? Yes, Asta, what you saying?
Yeah, so my email address is this, and if anyone wants to connect with me on LinkedIn, I'll be happy to share my LinkedIn profile and see if any person is interested to talk ahead on this.
Thank you, Asta. Any questions? Thank you, Asta. Thank you very much.
Yeah, thank you.
Dr. Surinder Rana, are you here? Anyone else want to share any problem? नहीं सर ये तो we'll be waiting for Dr. Surinder. He'll be joining meanwhile. Few minutes. Hello, Dr. Surinder is with us now. Dr. Surinder, can you hear us?
Yeah, I can hear you.
Yeah, okay. Sir, you are the, we are waiting for you. Now you can start sharing your problem, please, ma'am.
Should I just share my presentation?
Sure, sir, you can share your screen.
Just 1 minute.
Can you see my presentation?
Yes, sir, you can see.
Okay, should I start?
Yes, sir.
Yeah. Good afternoon, everyone. Thanks to Dr. Virendra Garg for giving me this invitation. I'm just going to talk briefly about the innovations in the field of therapeutic endoscopy, the problems which we as a clinician face, and some of the solutions which we have been able to find, and then what we expect our engineer colleagues and other technical colleagues to help us. First, I'll talk about this procedure, which is endoscopic necrosectomy. It's basically an endoscopic procedure which we do for patients who have got pancreatitis. Pancreatitis is a disease of pancreas which leads on to necrosis, and then this gets infected. So that the aim of this treatment is to remove this infected necrosis from the bed of pancreas to the stomach. So what we do is we take our endoscope into the stomach, make a hole on the posterior wall of stomach, and get into this cavity which has got the necrotic collection. So what we have to do is, this is how it looks like. So this is our stent which we have placed to create a hole. And then we are trying to remove this necrotic material with our accessories to the endoscope. The problem is the conventional gold standard is the surgeon's hand. So what surgeons used to do is get inside this necrotic cavity and then using their hand to find out what is viable and what is necrotic and then remove it. So what we are trying here is to replace the surgeon's hand with an endoscopic device which will get inside the cavity through an endoscope channel and then remove it. So what we conventionally do is, this is the sheath. It has got a basket in front of it, and this basket we slowly piecemeal remove it. But the problem is this cannot replace the surgeon's hand, and then it's a very long and laborious process where you keep on pinching out small pieces of necrotic material and keep taking it out. So there have been some solutions in last few years. These are the solutions which are now commonly used. This is the one which has been developed from Germany. This is over the scope you put a grasper. So what will happen is it will just close and open like a surgeon's hand and remove the necrotic material. So with this you can remove large chunks of material. But then again, it is not a perfect solution because it still takes a lot of time and you just cannot remove the necrotic material. This is a new solution on the left side which has been developed from a company in US. This is basically what it will do is, you can see the tip, it comes out through the endoscope, and then this is a cutting tip. So what it will do is, it will go inside the necrotic tissue, cut it, and then simultaneously suck it. So it is basically cutting and suction. So at present, this is the best solution, but then again, as you can understand, this is not a perfect solution. You need something which is like a human hand, which will go inside and then grasp the necrotic tissue and take it out. So this is one problem which I've just talked about. Another problem is, again, similar to what we do is drainage of intra-abdominal infected collections. So what we do is, it's a multi-step process. We see the fluid collection inside the abdomen through the stomach. We then use this endoscopic ultrasound scope. We first puncture it with a needle. Then we put this guide wire inside this. Then we dilate the tract using balloons. And then finally, we put a drainage tubes, which we call stents. So this, as you can understand, is a multi-step process, which involves multiple steps of puncture, pushing a guide wire, dilating, and then putting a stent. So this is laborious. You have a chance of slippage of wire. So again, you will have to start again. So again, there have been attempts to improve upon this technique. So this is how you do it: put the wire, use a balloon, dilate, and then put these drainage tubes on stents. So what has innovation has happened is this we have been working for last 5 years. This is the needle which we conventionally use to puncture it. So what we have done is we have modified this needle so that in this one needle itself, you have all the steps happening. That means this, what we do is we modify the tip of the needle. This is the design from our engineers. So we have modified the needle. So this becomes the dilating sheath. So in a one step, you are putting a needle out, then dilating with the sheath, and then we have placed a balloon here. So we have been able to get 3 steps into one so that it shortens the procedure and makes it more convenient for the endoscopist. But again, this is not the perfect solution. Then there have been some solutions from the West also. This is the one which is now conventionally used. This is quite expensive. It costs about 2.5 lakh rupees in Indian currency. So here what happens is they have also got a stent incorporated in the single device. And instead of needle, they have a cautery here. So what they do is they dilate it using a cautery, take the sheath across, and in a single step, you place a stent. So what we are looking forward is a cheaper solution here, because this is a metal stent. We want a device which we have manufactured where we can also incorporate a plastic stent so the device becomes user friendly, and in single step we can deploy the stent. And finally, the third solution problem which we are facing is this is a procedure which we do as a fine needle biopsy. Whenever there is a diseased organ for a diagnosis, we want to biopsy it. So this is the conventional needle which we use. But the problem is the accuracy of the tissue acquisition is about 70%. So what actually we want is we want the tissue course so that the pathologist can see the tissue rather than cytologist seeing the cells. So there have been some innovations from the West, but they are expensive. What they have done is they have modified the tip of the needle. So these are 2 designs which are patented designs. One is a Francine design and one is a Charcot design. So basically what happens is you modified the needle from a bevel design to this cutting designs where which you can have directly tissue being acquired rather than cells being acquired. But then again, these are not perfect solutions, although the accuracy has reached up to 95%. But the tissue course which we are obtaining from these needles are far from perfect. So these are the 3 clinical problems which I have just talked about. So if there are any questions, then I'll be more than happy to answer.
Any questions, please? Online? Can raise hands. Okay. Thank you, Surinder sir. Thank you very much.
Thank you so much. Thank you. Thank you.
Thank you. That concludes our pitching section for SOLVOMEDICA 2024. I would like to say big round of applause to all the presenters. There is a hand of Ravikant sir. Ravikant sir.
I have a question for Dr. Surinder.
Sir, I deal with this pancreatitis at our hospital, and I just need to ask you the duration in time, like when this endoscopic stenting procedure he does for that, if he's online.
Ravi sir, I will connect you with Surinder sir. Actually, he has left. He's left.
Okay. Done. Thank you.
I will say again a round of applause to our presenters and contributors. Again, the audience who have made this event a successful one. That's all for now, and we'll hope to meet next time again. Thank you very much.